Welcome to the Hospital Medicine Unplugged podcast. We are diving deep today into one of the most common reasons we admit patients to the hospital medicine service, acute diverticulitis. This is a condition that, well, while it seems straightforward sometimes in presentation, it's seen such a significant and rapid evolution in its evidence-based management over the last decade, particularly concerning when or maybe if we should be pulling the trigger on antibiotics.
That is precisely the challenge for the hospitalist, isn't it? The clinical and, frankly, economic significance of diverticulitis is just immense. I mean, we are talking about approximately 200,000 hospital admissions annually just in the U.S., and when you start factoring in things like readmissions, the cost of advanced imaging procedures, managing long-term sequelae, the cumulative healthcare burden is truly staggering. It exceeds $6.3 billion per year.
Wow. Okay, so our mission today then is to provide a structured, evidence-based deep dive into this really evolving landscape. We're specifically looking at recent guidance from high-impact sources, like JAMA and the NEJM, focusing on inpatient diagnosis, robust risk stratification, that critical and often confusing shift towards selective antibiotic use, and finally, the clear escalation pathways for both uncomplicated and complicated disease. We really need to leave this conversation knowing exactly who must be admitted and who actually benefits from IV antibiotics versus, say, simple observation.
Agreed. And to manage this condition well, I think we need to start with the fundamental science. Let's lay the groundwork first by reviewing the epidemiology, the core risk factors, and the mechanism of inflammation itself.
Okay, sounds good. Let's unpack the numbers first. We know diverticulosis, just the presence of those outpouchings, is incredibly common. Prevalence can soar up to maybe 60% by age 60. But it is important to reinforce for our listeners, right? The annual incidence of actual acute diverticulitis remains relatively stable, about 180 per 100,000 persons. What's really crucial to remember is that only a small fraction, perhaps 1 to 4%, of those who have the diverticulosis ever go on to develop that acute inflammatory attack.
Exactly. And this is where the demographics become quite interesting. Historically, we sort of thought of this strictly as a disease of the elderly, but recent data really confirms a shifting demographic trend. We are definitely seeing the incidence rising notably in younger populations, specifically those under age 50. And that complicates the differential diagnosis sometimes in the emergency department, especially when you're considering appendicitis or maybe gynecologic pathology.
Yeah, that rising incidence in younger patients suggests that age over 65, while still a major factor, clearly isn't the whole story. So what are the core non-age-related risk factors that drive this disease? The things we should be factoring into our risk stratification right when they hit the door.
Well, the list is quite comprehensive, and it highlights both systemic and structural vulnerabilities. Beyond just advanced age, we have to recognize there's a strong genetic component. Specific genetic variants like TNF-FSFI5 have been implicated. This suggests a predisposition may be linked to chronic inflammation or possibly motility issues. Furthermore, connective tissue disorders, think Marfan syndrome, Ehlers-Danlos, or even polycystic kidney disease, these are major risk factors.
Why do those connective tissue disorders specifically predispose patients to diverticulitis? What's the link there?
It's because the diverticula themselves are essentially herniations through the muscular wall of the colon. These connective tissue disorders involve defects in the collagen scaffolding, which inherently weakens the entire structure of the colon wall. So when you combine that sort of inherent weakness with high internal pressure, you really set the stage for those outpouchings. And speaking of pressure, lifestyle factors are absolutely paramount. Obesity, typically defined as a BMI of 30 or greater, is a significant independent risk factor.
Right. And we also have to consider the medications our patients might be taking chronically. These can certainly exacerbate or maybe even contribute to the initial event.
Precisely. Chronic use of opioids, for instance, leads to constipation, and that increases intraluminal pressure. Steroids cause immunosuppression, which can mask the inflammatory response but also increases the risk of perforation. And, critically, the use of NSAIDs significantly increases risk. They seem to impair mucosal integrity and potentially promote localized ischemia, which can contribute to microperforation. We also link systemic comorbidities, particularly hypertension and type 2 diabetes, to increasing susceptibility. This is likely due to microvascular changes that weaken the colonic tissue over time.
Okay, let's shift gears from risk factors to the actual disease mechanism, the why behind the inflammation. We always learn that diverticula are false diverticula. Can you clarify what that means structurally and maybe address why the sigmoid colon is almost always the epicenter of this disease?
Sure. Structurally, they are indeed false diverticula because they involve only the mucosal and submucosal layers pushing out. The outpouch, where the vasa recta, those are the small blood vessels, penetrate the circular muscle layer. These vascular penetration points are essentially inherent weak spots in the muscularis propria layer of the colon wall. Now, the sigmoid colon is the most common site primarily due to biomechanical factors related to its specific anatomy.
Ah, that's where the law of Laplace comes into play, correct?
It does, yes. The law of Laplace, for those who might need a quick physics refresher, simply states that the pressure within a cylindrical tube is inversely proportional to its radius. Since the sigmoid colon typically has the smallest diameter, the smallest radius of the entire large intestine, it naturally generates the highest wall tension for any given internal pressure. This concentrates stress right at those vulnerable spots where the vasa recta penetrate, leading to herniation and eventually diverticulosis.
Okay, so high wall tension plus these pre-existing weak points creates the anatomy. What's the actual mechanism then that flips the switch? What takes it from silent diverticulosis to acute, painful inflammation?
Well, acute diverticulitis seems to arise from a combination of both mechanical and biological factors. The traditional view really focuses on fecal stasis within the neck of the diverticulum. This leads to hardening of the stool and inspissated fecalith. This hard pizza stool can then cause erosion or obstruction, increasing the intraluminal pressure within that diverticulum and eventually resulting in a microperforation at the apex. That's what causes the acute mucosal inflammation we see.
But the research now shows it probably goes beyond just simple mechanical erosion, right? There's an emerging, powerful role for the gut microbiome here too.
Absolutely. Alterations in the gut microbiota are increasingly recognized as really central to this whole process. We see evidence of dysbiosis, which basically involves a decrease in beneficial bacteria. That results in a decrease in the production of short-chain fatty acids, which are vital for maintaining the integrity and energy of the colonic mucosal barrier. And simultaneously, there tends to be an increase in pathogenic gram-negative bacteria, things like E. coli and Enterobacteriaceae. So this microbial imbalance disrupts the mucosal barrier, promoting and probably perpetuating that initial inflammatory cascade.
And the physical outcome of that initial perforation really determines the severity of the disease we end up managing on the floor.
Yes, exactly. The sequel A depend entirely on whether that microperforation is contained or not. If the inflammation and maybe some fecal material are contained by the adjacent mesentery and surrounding structures, we end up managing a localized inflammation, which we call a phlegmon, or perhaps a walled-off collection, which is an abscess. This represents uncomplicated or maybe locally complicated disease. But if the perforation is free and the contents spill out into the peritoneal cavity, well, that results in diffuse, purulent, or even feculent peritonitis that immediately defines a surgical emergency with very high morbidity.
Okay, let's pivot now to the clinical side of things. How these patients typically present and how we should begin to triage them when they arrive.
The classic presentation, as you know, is often characterized by that triad we all learned in medical school: acute or maybe subacute left lower quadrant abdominal pain, fever, and leukocytosis. The pain is usually described as constant and dull and often develops over several days rather than suddenly.
But we have to caution our colleagues, right? Relying strictly on that classic triad can definitely lead to misdiagnosis, particularly in the elderly or perhaps those with atypical anatomy.
Indeed. Atypical presentations are actually quite frequent. If the patient happens to have a redundant or particularly long sigmoid colon, the inflamed segment might be displaced. It could pull the pain over to the right lower quadrant, mimicking appendicitis, or even down to the suprapubic area, mimicking a gynecologic issue. And in the elderly, the inflammatory response might be blunted, perhaps due to age itself or immunosuppressants like chronic steroids. This can result in just a low-grade fever and minimal leukocytosis, even despite a severe underlying process like a perforation.
So if the symptoms can be subtle or atypical, what signs on the physical exam should really raise our alarm bells?
The physical exam is still absolutely the cornerstone here. Localized tenderness, maybe some mild guarding in the left lower quadrant, that's typical for uncomplicated disease. However, in complicated cases, we must be really vigilant for signs of peritonitis, things like rebound tenderness and rigidity. Also look for a palpable mass, which could indicate a phlegmon or an abscess, or even specific signs of a fistula, like pneumaturia or fecaluria, which would strongly suggest a colovesical fistula.
Okay. When a patient hits the emergency department with suspected diverticulitis, what's the required initial laboratory evaluation before we jump to imaging?
We need to start with a complete blood count, a basic metabolic panel just to assess for dehydration or electrolyte abnormalities, a urinalysis to rule out a competing UTI, and critically, a C-reactive protein level.
Leukocytosis is part of the classic picture, as we said, but how reliable is it really for confirming the diagnosis itself?
It's surprisingly unreliable for pure confirmation. Leukocytosis is present in only about 55% of patients who actually have a fever. That's a key point for hospitalists to remember, especially when you're managing elderly or immunocompromised patients. However, the inflammatory markers are important for risk stratification. An elevated CRP, specifically a level greater than 150 milligrams per liter, has been shown in some studies to strongly suggest progression towards complicated disease.
Ah, okay. So we use the labs less for diagnosis and more for assessing the likelihood of progression, which brings us then to the gold standard, imaging.
Yes, contrast-enhanced CT of the abdomen and pelvis remains the indisputable diagnostic gold standard. It offers both incredibly high sensitivity and specificity, often approaching 99 to 100%. And for hospitalized patients, it's essential because it doesn't just confirm the diagnosis, it immediately classifies the severity, which is what dictates our entire management pathway.
What are the key CT findings that we as hospitalists absolutely must look for to determine the course of treatment?
The CT findings classify severity based primarily on the extent of the inflammatory process. Key signs include colonic wall thickening, typically defined as wall thickness greater than about 4 millimeters, and the presence of surrounding paracolic fat stranding, which just indicates local inflammation. The presence of complications is what dictates urgency. So we're looking for things like localized abscess formation, any extraluminal gas, air outside the colon, or free fluid throughout the abdomen, which immediately suggests generalized peritonitis. The CT is also our best tool for confidently excluding that broad differential diagnosis we mentioned, like an IBD flare, appendicitis, or critically an underlying colon neoplasia, which can sometimes mimic acute diverticulitis quite closely.
Okay, so once we have the clinical picture, the labs for risk stratification, and the definitive CT scan, the next crucial step is that triage decision. Who actually needs to be admitted for inpatient care?
Right. Hospitalization is now strictly reserved for essentially two groups of patients. Those with a confirmed complicated disease, so that means evidence of abscess, perforation, fistula, or obstruction on their CT, and those with specific high-risk features, even if the diverticulitis is technically uncomplicated, based purely on the imaging findings.
Let's detail those high-risk criteria, because this is really where the art of medicine meets the science of triage, isn't it?
Certainly. First, patients presenting with severe systemic symptoms must be admitted. This includes a high fever, say above 38.5 degrees Celsius, marked leukocytosis, or really any signs of systemic inflammatory response or early sepsis. Second, any degree of immunosuppression is an immediate indicator for inpatient care, whether it's from active chemotherapy, high-dose chronic steroids, or post-transplant status. The risk of rapid progression and perforation is just too high. Third, significant comorbidities like advanced cardiac, renal, or pulmonary disease reduce the patient's physiological reserve and generally warrant admission for closer monitoring. Fourth, an inability to tolerate oral intake, often manifesting as persistent vomiting or severe dehydration, necessitates IV fluids and therefore inpatient management. And finally, we also have to consider the non-clinical factors. If the patient requires intravenous analgesia for adequate pain control, or if they genuinely lack adequate home support for safe monitoring and rapid access back to care if things worsen, they should probably be managed as an inpatient.
That's a critical point. Admission isn't just about the CT finding alone. It's really a holistic assessment of the patient's overall fragility and their support system. And as you note, that's fully supported by current guidelines to minimize poor outcomes.
Absolutely. We're making a proactive risk assessment rather than simply reacting only to the imaging.
Let's focus now on the inpatient management itself, starting with the largest group, those with uncomplicated diverticulitis. This accounts for about 85% of cases overall, right? Yeah. So how do we define it again, and what's the standard supportive care we should initiate?
Right. Uncomplicated diverticulitis, again, means localized inflammation seen on CT without any signs of abscess, perforation, fistula, obstruction, or stricture. For these patients, supportive care is the immediate and often the entirely sufficient approach.
And that standard supportive care hinges primarily on bowel rest and adequate hydration.
Correct. Patients are typically initially kept NPO or maybe started on a clear liquid diet. We administer IV fluids to correct any hydration deficits they might have from poor oral intake or vomiting. Importantly, the diet could usually be advanced quite quickly, often within 2 to 3 days, as their symptoms begin to improve clinically. For pain control, we need to be judicious. Acetaminophen is generally the preferred analgesic. Opioids should really be minimized or avoided if possible, partly due to the risk of exacerbating constipation, but also because they can mask developing peritonitis. And as we noted earlier, NSAIDs are generally avoided due to that increased risk of microperforation and bleeding.
Okay, now let's tackle the major guideline shift regarding antibiotics in this specific uncomplicated group. We were all trained that diverticulitis equals antibiotics. What is the current, more nuanced stance?
Well, the current evidence emphatically states that antibiotics are not routinely indicated for all uncomplicated cases. This is a major practice change. It's based on robust, randomized controlled trials and subsequent meta-analyses demonstrating that for low-risk, immunocompetent patients, observation and supportive care alone are non-inferior to antibiotic treatment. In fact, in some studies, just supportive care resulted in fewer adverse events overall.
That concept of non-inferiority is really central to antibiotic stewardship, isn't it? Why specifically are we trying so hard to avoid unnecessary antibiotics in a condition historically managed with them?
There are clear downsides. Unnecessary broad-spectrum antibiotic use definitely drives resistance patterns, particularly in organisms like E. coli and Enterobacteriaceae, which, as we discussed, we know are involved in the pathophysiology. More acutely, it significantly increases the patient's risk of developing C. difficile infection, which can be absolutely devastating, especially in an elderly or multimorbid patient population. So the risk of those negative outcomes often outweighs the minimal, if any, benefit provided to an otherwise stable, uncomplicated patient.
So we're reserving antibiotics only for those patients with the high-risk factors we talked about in the triage section.
Precisely. We reserve antibiotics for the high-risk patient within the uncomplicated group. This includes the elderly, especially those over 80 years old, anyone with any degree of immunosuppression, those who present with persistent high fever or maybe a rising leukocytosis despite initial supportive measures. Also, pregnant women or patients with severe decompensated comorbidities. But if a patient is stable, immunocompetent, tolerating some oral intake, and a febrile, we can confidently initiate supportive management alone and just observe them closely.
Okay. Now, if antibiotics are deemed necessary for an admitted high-risk but still uncomplicated patient, what are the preferred regimens? And how do we think about the transition from IV to oral therapy?
Right. If the patient requires IV therapy upon admission, our first-line options need to target both gram-negative and anaerobic organisms. Common choices include intravenous ceftriaxone plus metronidazole or perhaps ampicillin-sulbactam. Now, if we're managing them as an outpatient from the start or preparing to de-escalate to oral therapy for discharge, preferred regimens are typically amoxicillin clavulanic acid or an oral cephalosporin combined with metronidazole. We generally aim for a total duration of therapy of about 5 to 7 days, but that's always adjusted based on their clinical response.
And what's the expected timeline for clinical improvement? Because presumably a lack of improvement is itself a mandate for escalating care.
Yes, clinical improvement, which means decreased abdominal pain, resolution of fever, normalization of inflammatory markers like CRP is expected relatively rapidly, typically within 48 to 72 hours. If a patient does not show objective improvement within that window, that's definitely a red flag. It warrants a prompt reassessment, maybe more aggressive hydration management, and most importantly, repeat imaging, usually another CT scan to rule out progression to a complicated disease state, such as a developing abscess that wasn't obvious initially.
Okay, let's move now to the more resource-intensive group.
Yeah.
The management of complicated diverticulitis. This progression involves specific anatomical complications and, as you said, requires a pretty non-negotiable approach to management.
That's right. Complicated diverticulitis, as we define it, involves progression to phlegmon, abscess, perforation, fistula, or obstruction. These cases absolutely mandate hospitalization, aggressive supportive care, and, yes, mandatory IV antibiotics immediately upon diagnosis.
For these patients, the antibiotic strategy is critical. What are the key regimens we should be using, and what kind of duration are we generally aiming for?
The strategy requires mandatory IV antibiotics that target both gram-negative and anaerobic bacteria with robust coverage. Preferred ID regimens include ceftriaxone plus metronidazole, ampicillin-sulbactam, or piperacillin and tazobactam. It's worth pausing here just to emphasize, for antibiotic stewardship purposes, that studies confirm the two-drug regimen of ceftriaxone and metronidazole is generally non-inferior to piperacillin and tazobactam for most complicated cases. This allows us to often spare the use of the broader spectrum agent when appropriate. The typical duration of therapy for complicated disease is longer, often targeting 7 to 14 days total. But again, this is adjusted based on definitive clinical and maybe radiographic clearance of the infection.
Let's talk specifically about managing an abscess, as this is probably the most common reason for immediate escalation beyond just medication. We talk a lot about the role of interventional radiology here. Is there a precise size cutoff that determines whether we should drain it or just treat it medically?
Yes, there is a really critical size threshold that guides intervention, which all hospitalists should probably memorize. If the abscess seen on CT is less than 3 centimeters in diameter, management can typically proceed successfully with intravenous antibiotics alone. We rely on the body's immune system, boosted by the antibiotics, to resorb that small collection.
But once we cross that 3 centimeter threshold, the management shifts pretty dramatically, doesn't it?
Absolutely. For abscesses that are 3 centimeters or greater in diameter, image-guided percutaneous drainage is the recommended strategy. This is performed by interventional radiology, usually in conjunction with ongoing IV antibiotics. This interventional approach is highly successful, actually, achieving resolution and avoiding the need for emergent surgery in up to 80% of cases. The goal here is to adequately decompress the infected collection, control the source of infection, and allow the antibiotics to penetrate better and clean up the residual inflammation. It effectively bridges the patient towards a later, potentially elective, surgical discussion if needed.
Okay, so beyond a failure of drainage, when do we actually call the surgeon for emergent intervention? What are the non-negotiable indications that transition this from a medical or radiological problem into a true surgical emergency?
Surgery is reserved for clear emergent indications, usually relating to diffuse peritoneal contamination. Primarily, this includes generalized peritonitis, whether we see purulent material or, much worse, feculent contamination on the imaging or during the physical exam. Free perforation, where the inflammation is completely uncontained and there's air or fluid throughout the abdomen, is an immediate surgical call. We also need to intervene surgically if there's clear clinical deterioration or persistent sepsis that is refractory to both aggressive non-operative management and attempted drainage. And finally, major complications like a complete colonic obstruction or a fistula that requires immediate definitive repair would also necessitate urgent surgical input.
And for those emergent surgical cases, what's the usual approach? Is it always a stoma, colostomy?
Not necessarily always. The specific surgical procedure depends heavily on the patient's physiological stability at the time of surgery and the extent of contamination found in the abdomen. If the patient is relatively stable and the contamination is maybe mild to moderate, the surgeon might opt for what's called a primary resection and anastomosis. They remove the diseased segment of colon and rejoin the healthy ends right away, thus avoiding a stoma. However, if the patient is unstable, septic, or if the contamination is severe, like widespread feculent peritonitis, the surgeon will often opt for a damage control procedure. Most frequently, this is a Hartmann's procedure. That involves resection of the diseased sigmoid colon, but then formation of a temporary end colostomy with the rectal stump sewn closed. This is followed by a second surgery, usually months later, to reverse the colostomy.
That detailed decision-making process really highlights the complexity here. Now, let's take a moment to address special populations, because diverticulitis can behave very differently depending on the patient's underlying health status. Let's start with the elderly patient.
Right, the elderly population, let's say those over 65, and certainly those over 80, carries a greatly increased risk for complications. This is due to multimorbidity and, critically, often an attenuated or less reliable clinical presentation. Their inflammatory response is often blunted, meaning they might not mount a high fever or a significant leukocytosis, even with something serious like a contained perforation or an abscess brewing.
So their symptoms might be subtle, but the underlying disease could potentially be more severe. What does that mean for our diagnostic and management thresholds in this group?
It means our index of suspicion has to be significantly higher. We really need a low threshold for ordering that contrast-enhanced CT scan, regardless of whether their white count or CRP is markedly elevated. For management, antibiotics should generally be administered for any localized complicated disease, or if there are really any systemic symptoms at all, even if the findings seem relatively mild on imaging. And surgery in this group is highly complex. Decisions must be truly individualized based on the patient's overall physiological reserve, their frailty index, and potential quality of life impacts post-surgery, rather than just reacting to the anatomical finding on the CT.
Okay, the other extremely high-risk group we need to discuss is the immunocompromised patient, those on chronic steroids, chemotherapy, or post-transplant immunosuppressants.
Yes, these patients represent the highest risk population, without a doubt. They are at extreme risk for rapid progression to severe or complicated disease and overwhelming sepsis, even when their initial presentation appears deceptively mild. They simply don't have the robust physiological containment mechanisms that a healthy immunocompetent patient does.
So what does that mean for our standard inpatient management protocol for the immunocompromised patient with diverticulitis?
It basically mandates the most aggressive possible approach from the outset. Antibiotic therapy is absolutely mandatory for them, regardless of the initial apparent severity of the diverticulitis on CT. Furthermore, hospitalization is indicated for any signs of systemic illness, even if it's just mild abdominal tenderness or a low-grade fever. A perforated diverticulitis in an immunocompromised patient carries exceptionally high morbidity and mortality rates, sometimes exceeding 30 to 50%. Therefore, early and quite liberal surgical consultation is absolutely crucial. We want the surgeon involved well before the patient potentially spirals into septic shock.
And thinking longer term, given their high risk of recurrence and future complications, what should we be discussing with them regarding ongoing care?
We should definitely be discussing the option of elective resection with them for long-term management once the acute episode completely resolves. This really becomes a primary prevention strategy in this group, aimed at eliminating the risk of future, potentially fatal complications down the road.
Let's briefly summarize the spectrum of complications we've touched upon that drive these high-risk admissions and contribute to that huge $6.3 billion annual burden beyond just abscess and free perforation.
Sure. The major long-term sequelae are really crucial for the hospitalist to recognize and anticipate. Fistula formation is relatively common, particularly affecting the bladder, resulting in a colovesical fistula. These patients often present with symptoms like pneumaturia air in the urine or fecaluria. Recurrent inflammation can also lead to scarring and eventually obstruction or stricture of the colon, which usually requires definitive surgical management. We also see chronic symptoms persisting in some patients, things like nagging pain, altered bowel habits, even after the acute infection seems completely cleared. This can drastically reduce their quality of life.
And are there any clinical or laboratory predictors we can use to identify patients at higher risk of progressing to these sequelae?
Yes. The predictors generally include advanced age, as we discussed, any form of immunosuppression, and the presence of significant comorbidities. In terms of inflammatory markers during the acute phase, a CRP level consistently greater than about 140 milligrams per liter or a white blood cell count greater than 15 times 10 to the 9th power per liter are pretty strong indicators associated with an increased risk of progression to abscess or the eventual need for intervention.
Okay, this brings us logically to the final stages of care: follow-up and secondary prevention. This is where we focus on managing recurrence risk and also screening for the possibility of underlying malignancy. The timing and necessity of post-acute colonoscopy seems to have evolved significantly too. What are the current guidelines on that?
The guidelines are now quite clear that follow-up colonoscopy needs to be risk stratified based on the severity of the initial presentation. For patients who presented with complicated diverticulitis, meaning they had an abscess, a perforation, or a fistula, colonoscopy is strongly recommended about 6 to 8 weeks after the acute episode has fully resolved. This timing is critical because the main goal here is to definitively exclude an underlying malignancy or perhaps advanced adenomas that might have masked or mimicked by the acute inflammatory mass. Studies do suggest the risk of malignancy is somewhat higher in complicated diverticulitis compared to the general population.
What about the vast majority of patients who just had uncomplicated diverticulitis? Do they all need a post-infection scope?
No, not routinely anymore. For uncomplicated cases, the colonoscopy may often be deferred if the patient has had recent, adequate colon cancer screening prior to the acute attack. However, it should still be strongly considered, especially after the very first episode, and particularly if they present with any alarm symptoms. Things like unexplained weight loss, new or persistent rectal bleeding, iron deficiency anemia, or a significant change in bowel habits. These are indicators that really demand endoscopic evaluation to rule out cancer, regardless of prior screening.
Okay. So, once the acute episode is fully resolved, the goal shifts entirely to preventing a recurrence, which we know is most likely after the first attack. How do we best counsel our patients regarding secondary prevention strategies?
Lifestyle modification is absolutely paramount, and it really centers around dietary fiber. The strongest recommendation, supported by significant data, is for a high-fiber diet after recovery. We should encourage focusing on fruits, vegetables, and whole grains. The mechanism here is thought to be that increased fiber bulk decreases intraluminal pressure in the colon, specifically counteracting that high wall tension dictated by the law of Laplace we talked about earlier. This hopefully reduces the risk of further outpouching and subsequent inflammation.
And what about that old advice we used to give about avoiding nuts, seeds, and popcorn, especially during the acute phase? Is that still relevant?
We can confidently tell patients that advice is outdated and not supported by evidence. During the acute phase itself, there's no strong evidence for any specific, strict, restrictive diet. We generally advance the diet simply as tolerated, starting typically with clear liquids and moving rapidly back towards normal foods within those first few days as symptoms allow.
Good to clarify. Beyond diet, what other lifestyle changes should we be stressing for their long-term colon health?
Regular physical activity is important. Maintaining a normal body weight, aiming for a BMI, ideally between 18 and 25 kilograms per meter squared, and the avoidance of smoking. Also, avoidance of chronic NSAID use. It's vital, though, to clarify that this avoidance of NSAIDs is distinct from low-dose cardioprotective aspirin use, which should typically continue if it's otherwise indicated for cardiovascular reasons. And we must also temper patient expectations regarding pharmacologic prevention strategies. While many patients ask about them, the high-quality evidence simply does not support the routine use of agents like mesalamine, rifaximin, or probiotics specifically for preventing recurrence of diverticulitis. These agents can be expensive and, unfortunately, have not consistently proven beneficial in reducing future attack rates in large trials.
Okay, and finally, let's address the long-term surgical decision. For years, the rule of thumb was that elective colectomy was recommended simply after 2 attacks of diverticulitis. Has that hard rule truly been abandoned now?
Yes, that guideline has definitely changed, and it represents a major shift in practice philosophy. Elective surgery should no longer be based solely on the number of previous episodes a patient has experienced. We now recognize that many patients can have 2 or even 3 relatively mild attacks and continue to live healthy lives without needing major surgery.
So, if not the number of attacks, what drives the decision for elective surgery now?
The decision has to be highly individualized and really made in partnership with the patient. Current indications are more focused on patients who have developed complicated disease sequelae, like a persistent stricture or a fistula. Or it might be considered for patients with smoldering chronic inflammation that never fully resolves between attacks, or those experiencing frequently recurrent diverticulitis that significantly impacts their quality of life. We're increasingly using patient-reported outcome measures and quality of life indices, like how often are they missing work? How often are they having persistent pain, to help guide that discussion. True shared decision-making between the patient and the surgeon, focusing on the functional impact of the disease, is absolutely essential now.
This has been an incredibly thorough review, really hitting on all the complexities of the current evidence landscape for diverticulitis. Let's quickly summarize the key takeaways that should ideally change practice for hospitalists starting tomorrow.
Okay, first, the management approach to uncomplicated diverticulitis is fundamentally selective and conservative. Remember, antibiotics are not routine unless specific high-risk features are present. Second, contrast-enhanced CT remains the gold standard not just for diagnosis, but crucially for accurate risk stratification and guiding initial management. Third, that 3-centimeter abscess threshold is critical to remember. Generally drain those collections that are 3 centimeters or greater and manage the smaller ones medically first. And fourth, IV antibiotic therapy and a very low threshold for admission are mandatory for all immunocompromised patients, regardless of how mild their initial presentation or CT findings might appear.
The continuous refinement of when we intervene versus when we should rely on the body's natural defense mechanisms really highlights the constant evolution of hospital medicine. The management of diverticulitis is truly a balancing act, isn't it? Between the need for acute source control on one hand and meticulous long-term prevention on the other. In an age where these elective surgery indications are constantly evolving, consider this. How does this shift from basing surgical candidacy purely on the number of attacks to focusing instead on quality of life in the presence of chronic symptoms fundamentally change our shared decision-making process with patients? It really prioritizes function over just pure anatomy or episode count.